Hi, everyone. I'm Figan Yizirolu, Executive Director of the Biobehavioral Institute in Great Neck, Long Island, New York. I am on the Scientific Advisory Board of the Anxiety and Depression Association of America and the International Obsessive-Compulsive Foundation. I have been working on OCD and related disorders for many, many years, and I'd like to thank ADAA for inviting me today to talk about BDD and its treatment. So for today's session, we're going to have three objectives. One is to recognize and diagnose variants of BDD, look at the development and maintenance of BDD, and three, what are the appropriate treatments for BDD. I'm going to do a brief introduction to BDD, talk about differential diagnoses, look at comorbidities, how do we assess for BDD, how do we engage patients and families into treatment. I'm going to propose my CBT model and talk about what are appropriate and inappropriate treatments based on this model. Look to see if there are any other therapeutic interventions that might be valuable to us in the treatment. And finally, relapse prevention. So let's look at Intro to BDD. In 2003, with the advent of DSM-5, there were two extra criteria that were added. One was the repetitive and compulsive behaviors, such as mirror checking, skin picking, camouflaging, etc., all of which we will get into in detail. An insight specifier with good, poor, and absent insight. If we look at prevalence rates, it's about 1.5% to 3% of the general population, with an onset around age 12 to 13, early adolescence. And male-female ratio is 1:1, although some studies indicate that females have a higher propensity, but that may be, in fact, due to the fact that females in general tend to seek treatment more often. Quality of life is extremely poor for this population. It's poorer than those of diabetics, those who have had recent myocardial infarctions, and depressed individuals. If we look at prevalence in medical and dental practices, we'll see that we can note that BDD is almost in every practice. In cosmetic surgery, we have 5 to 7% of the population that has BDD. In our dermatology clinics, it's about 12%. Orthodontic surgery, which is jaw surgery, again, very high, 11%. Rhinoplasty surgery, rhinoplasty clinics, rather, 20%. And dentists see about 7.5% in their population, those individuals who might be coming for whitening or straightening of the teeth. Any part of the body may be affected or of concern, although the facial feature is of utmost importance. The area that is primarily affected is the skin, color of the skin, the shape, size, or asymmetry of any particular feature. However, other parts of the body may also be affected, such as one's genitals, breasts, buttocks, abdomen, hands, feet, height, and we're going to talk about muscle dysphoria a little later on. Associated behaviors. Well, these are the compulsive behaviors, such as reassurance seeking. Am I attractive? How does my hair look? Am I losing my hair? Is my skin smooth? Do I look pretty in this dress, etc. Tanning salons, going to tanning salons in order to have smoother skin, to look more youthful, to have a different color. Positioning, camouflaging, for example, facing one side of your face, thinking that side might be more attractive. Camouflaging, wearing a baseball cap, pinning your hair up, putting your hair back, etc. Skin picking, again, trying to get out blemishes, pimples, in order to have smooth skin. Social comparisons, comparing oneself in school, work, in a shopping center, anywhere, is my particular body feature more attractive, less attractive than someone else's. Social comparison can also be with looking at models, looking in the magazines, so not necessarily in vivo. The most prominent avoidance behavior is mirror checking. Most of these individuals check the mirror constantly, trying to seek reassurance that their appearance is improving, wondering if they look any different from moment to moment. And sometimes because we feel better about ourselves, it's a better day in general, we may in fact see ourselves looking better. So this reinforces that repetitive behavior of going back. But ultimately, a certain percentage of individuals become discouraged by the mirror checking and start avoiding mirrors. Excessive grooming refers to wearing excessive makeup, doing your hair over and over again, using various different beauty products to improve one's appearance. There are many emotions that are involved in BDD, anxiety, depression being only two of them. Other emotions that are prominent are shame, disgust, and anger. One is ashamed of the way one looks. Your body is something you can't really avoid or escape from. You're carrying it with you at all times. So it's very hard not to have a reaction to one's body if you have BDD. You're angry because you can't do the things you want to do. You're angry for having BDD. You're angry because others you believe are talking or laughing or negatively evaluating you, or you're angry at the surgeon for not getting the appearance that you want. Variants of BDD. We said muscle dysphoria was one of them. These are usually men who want to look very, very muscular. They want to have a six-pack. They do everything in their power to have a certain body build. In order to achieve this six-pack or appearance of muscularity, masculinity, they usually will exercise excessively. They will do weightlifting. They will resort to anabolic steroids. And that's very important to assess for, because we know that anabolic steroids could lead to a lot of damaging side effects. They usually resort to taking vitamins or proteins or eating a certain diet. They may mimic very much an eating disordered individual, except that they feel scrawny, they feel small, and they want their appearance to change. Skin picking is another variant. About 1/3 of BDD individuals pick their skin in order to remove blemishes, blackheads, whiteheads, to get a smoother looking skin. They'll use their fingers, tweezers, or any particular tool to attack the imperfection. Obviously, as a consequence, they produce scars, disfigurements, sores, infections, and of course, this leads to other problems and more discouragement about their appearance. Hair pulling in BDD is similar to trichotillomania in that it could affect any particular body part, but the goal here is to improve one's appearance. Differential diagnoses. Let's look at OCD versus BDD. We know that there are a lot of similarities. In fact, many of the BDD patients that come in to my practice come in with a diagnosis of OCD. They have obsessions, they have compulsions, they're concerned with perfectionism. They do respond to similar treatments in terms of CBT, although there are some differences that we will get into later on. And they respond to similar medications, but higher dosages. The differences are that BDD individuals have higher overvalued ideation, more depressed, less anxious than OCD individuals, and they have much more suicidal attempts and ideation. What is overvalued ideation? Overvalued ideation is a conviction in your belief. and whether it's accurate, whether it's reasonable, whether other people think the same way as you do, whether you think your belief is due to your BDD or to actually a deformity in your appearance. So the overvalued ideation may be high or low, and a belief may be, for example, I believe that my nose is crooked. Social anxiety is very similar to BDD, the difference being that the judgment, the criticism, the evaluation is on appearance rather than whether you're eating properly, speaking properly, writing a check properly, or whether you're being criticized for a particular behavior rather than about your appearance. We know that in eating disorders, there are a lot of similarities, especially around a misperception of one's appearance. As in anorexia, the person may feel or believe that they are heavier than they really are, similar to BDD. There are obsessions and compulsions, but the difference being that the compulsions in eating disorders is around food, and the appearance concern in eating disorders is solely around shape and weight. In depression, there is also a concern about one's appearance, but in BDD, this is the prominent feature, whereas in depression, there are many other symptoms. Also in BDD, the belief about your appearance tends to fluctuate less, so your overvalued ideation is higher. As I said earlier, 1/3 of skin pickers are in BDD, but there are many skin pickers who don't have BDD. The difference is that if you're picking because you want to improve your appearance, then it's skin picking comorbid with BDD or a variant of BDD. And if it's rather an internal drive, pleasure seeking, a habit, then it's skin picking unrelated to BDD. Let's look at the comorbidities, which are very similar to some of the things we just discussed in differential diagnosis: OCD, social anxiety, depression, eating disorders, but we also have comorbidities of suicidality, substance abuse, and personality disorders. Suicide is very, very important in BDD because 89% of the population obsesses about suicide, thinks about how they would actually commit suicide. 29% attempt suicide, and about 3.35% completes their attempt. Suicide needs to be assessed at every session, and a plan has to be in place. Substance abuse develops after BDD, often as a way of self-medicating oneself. Often these are individuals who have more severe BDD. They need more intensive treatment. They attempt suicide more often and are hospitalized more often. Many clinicians believe that you should first get the substance abuse under control and then get treatment for BDD. I, on the contrary, think if you can treat the substance abuse with the BDD, your prognosis is going to be much better. If the BDD is untreated, they will resort back to some form of substance in order to reduce anxiety, depression as a coping mechanism. So we have had many individuals who are involved in a substance abuse program as well as in our BDD programs at the same time. Personality disorders that we see commonly in BDD are avoidant, dependent, obsessive-compulsive, and paranoid. It makes sense because obviously in BDD there's a lot of avoidance behaviors going on. They are misinterpreting other people's behaviors or actions as criticism, judgment, or evaluation of them. So they may think that people are talking about them, looking at them, laughing at them. They tend to be dependent and certainly perfectionistic and ritualistic. About 55% of borderline personality disorders also have comorbid BDD. If they do, then what we recommend is a DBT program at the same time as they're going through a BDD program. Depression as a variant, if they have depression along comorbid with the BDD, we certainly recommend behavioral activation, which is actually good for BDD anyway, because they tend to be avoidant and 40% are homebound. Cognitive restructuring, both aimed at depression as well as BDD, pharmacotherapy, and of course having a safety plan in place. So if you have a comorbid condition, what should you treat first? Well, the magic wand question. If I were to wave the magic wand and take away your distress, improve your functionality, what would you like me to treat first? Sometimes, obviously, you can treat two conditions at the same time, and that might be preferable. For example, somebody may have a contamination fear as well as an appearance concern. So if you're doing in vivo exposure, obviously they're being exposed to various environmental stimuli, which they may perceive as being contaminated, while at the same time other people are observing their appearance. How do you assess for BDD? So I know most of you are really interested in treatment, so let's go on to assessment. In your first consult visit, regardless of the reason for the referral, I would suggest you ask every single individual, are you concerned with your appearance, and do you mirror check? This will clue you in as to whether they have BDD. If you believe they have BDD, then the next is about what are their particular concerns. And often more than one body part is involved. So you may want to assess which is the most prominent body part of concern, and second, third, fourth, etc. Reviewing a typical day usually clues you into how the BDD affects them, what they're able to do, what they're not able to do, and enables you to set up a hierarchy that we will get into later on. Some of the measurements that we use is the Body Dysmorphic Disorder Questionnaire, which is basically what I just reviewed. Are you concerned about your appearance? Do you mirror check? Does it produce distress? Is it affecting your functioning? The Yale-Brown Obsessive-Compulsive Scale modified for BDD is a severity questionnaire. It does not assess whether one has BDD or not. The overvalued ideation scale is a scale that we developed in around 1996, I believe. It's available on the internet. You could have access to it, or you could write to me and I'd be happy to send it to you. It's what I reviewed a little earlier, basically looking at the conviction of the belief. My forehead is large and I'm never going to get a date. Is this a reasonable thought? How convinced am I that this is accurate? How much do I believe in this? Is this due to my BDD or not? Which assesses for insight, etc. Then you go on to psychoeducation. So you want to teach families and patients about BDD, the biological, psychological, and social influences of BDD. I'm going to present some of the resources that you may want to give patients or look at yourself. What is the difference between appearance and body image, and what is our CBT model? Here are some of the resources. Feel free to take a snapshot of it or refer to it later on. I just want to point out that there are two manuals that actually go into the treatment, step-by-step treatment of BDD. And one is David Veal and myself, a treatment manual. And the other is by Phillips, Sabina Wilhelm, and Gail Steckety. Biological influences. Well, we have neurobiological influences. the SSRIs and the SNRIs, which is, for example, fluoxetine, Zoloft, etc., and Afrinil. These medications are used at very high dosages, higher than even in OCD. Visual processing factors, detail versus global processing. Jamie Fusner at UCLA has done a lot of work on this, in which individuals BDD are more detailed oriented in their perception of themselves, in their perception of others, neutral objects, etc. Neural circuitry influences, such as the frontostriatal and temporal limbic systems. Genetics, we don't have a lot of information, but we do know that 8% of the population has a family member who also has BDD. Psychological influences are bullying, teasing, abuse, rosacea, acne, and puberty. Bullying, we just published a study that shows that BDD individuals tend to have significantly more bulliers than OCD individuals and general population. Teasing is extremely important in this population. They recall going back to childhood, being teased for particular body parts. Dr. Soni Kamlani and I published a paper indicating that sexual, physical, and emotional abuse is higher in this population compared to OCD and general population. Rosacea, acne, and puberty also may lead to development of BDD, and certain body parts may be conditioned, as we will see in our CBT model. Social influences could be, for example, observing a family member, looking in the media and noticing other people are more attractive. We know that there's an increase in cosmetic surgery over the years. There's more of an emphasis in looking a particular way. We know that culturally, there's a tremendous influence in what is considered beautiful at any given time. And that changes from time to time or from country to country. And these are factors that may influence the development as well as the maintenance of BDD. Next is body image versus appearance. Well, appearance refers to the actual observable anatomical feature, and body image is really a mental representation of the way we look, the mental picture we have about the way we see ourselves, what we think about ourselves, and how we feel about ourselves. While body image may change, appearance anatomically, we do not change unless we go for surgery. One of the things we emphasize to patients is that their body image may in fact change if they allow us to do therapy in looking at their perception, their sensory input, what they're thinking, what they're valuing, what their belief systems are around about appearance, and how do they feel about themselves. If we can modify visual and sensory input, values, and emotions, we may be able to modify this mental representation that they have in their mind. Once we get to the point of trying to engage the patient, we need to really be preparing the patient for treatment. You have to establish credibility. And the way to do that is really to work with the patient at where they are, meaning they may not be able to come into your office. They may not be able to be seen. They may not like going out during the daytime. They may like nighttime. So you may have to maybe talk on the phone. You may have to meet them in the car. Maybe they can't come into the waiting room. So work with the location and whatever the patient feels comfortable initially. Establish a therapeutic alliance by establishing credibility, by asking the various different questions about appearance, which most clinicians, the patient will tell you, have never asked them. Be empathetic and emphasize that they're not functioning the way they want to. And therefore, we need to really help them to achieve their goals on reducing distress and depression, and achieve their goals of whether it's dating, going to school, working, etc. We may use some motivational interviewing techniques to engage the patient. We have to recognize the ambivalence and resistance in patients. What are the treatment interfering behaviors? Don't argue or directly confront the patient. Try to explore their resistance and ambivalence. Look for common goals. And again, establish therapeutic alliance. There are 4 principles of motivational interviewing. One is expressing empathy, which is reflective listening, rephrasing, just feedback to them about what they're expressing, what they're feeling. Developing a discrepancy. While they want to go for surgery and they want to change their anatomical appearance, and they feel that they can't engage in treatment therapy because it's not going to be helpful. On the other hand, they want to socialize, they want to date, they want to do things that they would need to engage in therapy to reduce their anxiety about. Rolling with the resistance. Well, maybe saying something like, maybe you're not ready for treatment. Maybe you think it's too difficult at this time. Maybe you need to just go on the way you are. Supporting self-efficacy, meaning, well, you know, you've dealt with and coped with anxiety and depression in the past. You've been successful in developing strategies in other distressful situations. So you could do it in this situation as well. So ask open-ended questions, reflective listening, summarizing, doing a pros and cons, what are their options, asking for elaborations, and asking for the worst case scenario. What happens if you can't go for surgery? And what do you want to be remembered for on your deathbed? As you're preparing them for readiness for engagement, you may want to refer to Theory A and Theory B, which I often do. Theory A is the theory that they hold dear to their heart, which is, if I don't change my anatomical appearance, I will never be happy, and I need to change. In order to change my appearance, I need to anatomically change my appearance, which means I need to go for cosmetic surgery, most likely. Theory B is the theory that I hold, and that is that the flaw in appearance is due to the mental representation. And what we need to change is not your appearance, but this mental representation that you hold about your appearance. So I asked them to give me about 3 to 4 months so I can work on this mental representation, and hopefully that will begin to reduce their distress and improve their functioning. What are the appropriate treatments? CBT, medications, and perhaps ACT for those who are unable to engage in ERP initially. Inappropriate treatments are cosmetic surgery and psychoanalysis. Cosmetic surgery usually leads to worsening of symptoms, which is why we want to discourage individuals from going for surgery. There are very few patients that improve improve their satisfaction, rather, about their appearance to some degree with surgery. Majority remain dissatisfied, but more importantly, their symptoms actually worsen as a consequence of the symptoms. Okay, here we are, finally in treatment. So here's our social learning or CBT model. First, we have a biological predisposition, right? Like for any other disorder. Then we have operant condition, which means basically rewarding the individual as they're developing during childhood. So instead of Johnny being rewarded for playing the flute well on stage, Johnny's rewarded for looking great, being taller than the other boys, being very handsome, adorable, etc. A lot of emphasis maybe on appearance, not only with the individual, but in general. So they could also see their siblings being rewarded for, or their mother being very concerned about appearance. Then that's developmentally what's going on. And then we have evaluative or classical conditioning, meaning that, remember, abuse, teasing, bullying, rosacea, acne, puberty? Well, those are our unconditioned stimuli. Those usually lead to feelings of anxiety, depression, disgust, shame by themselves. But if those particular things, factors, get conditioned to a particular body part, then that particular body part will ultimately be able to elicit the same responses of anxiety, shame, depression. So if somehow I associate my forehead with being teased, being bullied about it, then I may feel shame, anxiety, and I may then engage in avoidance or mirror checking or reassurance seeking. And then I develop certain cognitions and beliefs around these particular areas of concern. And then my particular behaviors actually reduce the anxiety, shame, so they're negatively reinforcing, right? So if I camouflage, if I engage in certain responses, then my anxiety, shame, and depression and anger may lessen. So they become operantly or negatively reinforcing. So this is basically an acquisition and maintenance model for BDD that will help you in your treatment of BDD. If we look at our success rate with CBT, then we notice that about 28% are in full remission between 1 to 4 years. 57% in partial remission, and that is because most people become satisfied with a certain amount of improvement and they don't want to keep going further. So I generally like to encourage patients to go to full remission rather than being satisfied with partial remission. If we look at CBT compared to anxiety management, we found that CBT group was even better than anxiety management group. So not only individual, but even group therapy is successful. I have to say that for most BDD patients, once a week treatment is not sufficient. These individuals often need intensive treatment of long duration. They need to be taken out. They need to have in vivo exposure several times a week. Their challenges to treatment are overvalued ideation, the insistence on cosmetic surgery, whether the individual is homebound, and about 40% are homebound, whether they're self-referred or other referred, because we know that motivation will be dependent on whether they come for treatment themselves or not. If they have comorbid conditions of suicide, depression, and substance abuse. And family involvement is extremely important in that we don't want families accommodating BDD individuals. For example, if they don't want people being invited to the house because they don't want to be seen. On the other hand, we don't want antagonistic behavior on the part of the family either. So we need to teach families of patients to neither be accommodating nor antagonistic. if we look at how we approach different symptoms, if the person has negative thoughts about appearance and are obsessing, we may want to do attentional and task concentration, which I will get into, but basically it teaches the individual to be externally focused rather than internally focused, and cognitive restructuring. Maladaptive interpretation is when they are misinterpreting the behaviors of others as being judgmental, critical of them. Here we want them to generate alternative solutions and cognitively challenge these thoughts. If they have high negative emotions, we may want to teach them some emotional regulation skills. And maladaptive coping strategies actually refers to how do we deal with their compulsive behaviors. And here ERP, exposure and response prevention, and mirror retraining is most effective. Of course, homework should be given throughout treatment and in between treatments, even if the treatment is on a daily basis. So let's look at each individual behavioral intervention. Some of the cognitive errors and thought patterns are all or nothing. Because I look this way, I will always be ugly. All or nothing thinking. Mind reading. I know the person over there is thinking about my nose, my big ears. Fortune telling. I know I won't have fun at that party because nobody will talk to me. Everyone is going to find me unattractive compared to Sally. Selective attention, magnification. Everyone is looking at me. Everyone's looking at my nose, my ear, my eyes. Discounting the positives. Well, they're my parents. Of course they think I'm attractive. Then you want to look at their values and how much time do they actually spend on their values. So you ask individuals to give you a list of their values. And believe it or not, this is very hard for patients. Here is an opera singer who believed that artistic achievement was important, education, attractiveness, family and friends, and money was important, but not that important. So then I asked the individual, if we look, all of the percentages should add up to 100. And then how much time are you actually spending on these values? And to their surprise, they will find that probably 99% of the time is spent on the value of attractiveness. And yet they will claim that attractiveness is perhaps not as important as other values. So you want to realign the values with the time spent on the value. Second, you do a pie chart on self-esteem. What affects their self-esteem? Usually these individuals have low self-esteem because they're placing all of their value on themselves on appearance, which they think they're ugly. So what about their work ethic? What about their grades? What about their intelligence? What about their social skills? Trying to build up their self-esteem by looking at other areas that may affect one's self-esteem in general. Mirror retraining has to do with the work that I mentioned of Jamie Fusner of detail versus global processing. So you may begin by having the individual look at themselves from head to toe in the mirror and describe themselves in an objective manner. So it may be, I have brown hair, my eyebrows are 2 inches long. I have about half an inch between two eyebrows. They're slightly curved. My eyes are almond shaped. My nose is about 2 inches long. There is about a 1/4 inch between my upper lip and the bottom of my nose. I have an oval face. My neck is about 3 inches. I have a part in my hair, I forgot that, going to the left. And you do that all the way through to the shoe size that you may have. The idea is to describe yourself in an objective way without any adjectives attached of small, big, ugly, evaluative, in other words, non-judgmental. Exposure and response prevention is repeated exposure to the situations that they have been avoiding. And by repeated exposures, habituation occurs, which is when fatigue occurs as a result of constant neuronal stimulation. In 1972, Grove and Lynch stated that this habituation occurs in the brainstem reticular formation and specifically in the mesencephalon. So the course of behavioral treatment is building a hierarchy, decreasing compulsive behaviors, doing in vivo exposures, and maybe exaggerating the flaw depending on the individual. Let me go back a moment and just state that if you're doing ERP correctly, you will be exposing the patient to different contexts, and you will be doing it over and over practicing, overworking the individual. The reason I mention this is because an inhibitory learning has been proposed as well as an explanation of what happens during exposures. And this really, rather than habituation, that maybe inhibitory learning is important because the conditioned stimuli the conditioned response may actually reappear in the absence of the unconditioned stimuli in the future. So the conditioned stimuli and concern about your appearance may appear in a context after you've been treated. So an explanation may be that you need to expose the person in different contexts and you have to do it over and over. Today, I can't get into inhibitory learning. That's not the purpose, but just know that that might be another explanation besides habituation. Let me go on to a case example of Billy. Billy was a 20-year-old male who was preoccupied with his masseter hypertrophy. Those are muscles in the jaw, and he wanted to look like Johnny Depp. He had come home from college, could not go back to his old campus. He started withdrawing more and more, and he started abusing alcohol. And he was very angry with his family and friends, angry with family for not providing surgery. So one is we want to look at what is Billy doing day to day? What is he able to do? What is he unable to do? So here are some of the things that we found. If he was in his room listening to music, he was pretty calm. If he went for a walk around the block, he already started becoming anxious. If he had to make eye contact while walking around the block, more anxious. If he had to go into Starbucks and make no eye contact and walk out, he was anxious. So his anxiety increased with more and more contact, with finally being able to talk to someone, especially someone of the opposite sex, and then finally going into a university campus and ultimately into his own university campus. At the end of treatment, we're looking at, is the individual less distressed? Are they functioning better? Have they changed their thoughts? Often they're able to change their thoughts. They're certainly able to do a lot more. One of the first things you notice is behaviorally, they're able to go out more, do many more things. They may feel less anxious, less ashamed, so there's a decrease in their negative emotions. What takes a very, very long time is the perception. They may feel slightly less unattractive, but they continue to feel unattractive for some time. So don't let this discourage you. Just keep going and working, and ultimately that will also change. If the individual is not willing to engage in ERP directly, we had a study done by Suzanne Main and myself in which we illustrated that after 10 attempts of doing behavioral exposure experiments, and we were unsuccessful, we attempted ACT, and after ACT, the patients were more able to engage in ERP. Attentional training and task concentration is basically moving the person from internal focus to external focus. So one of the things you want to do is assess the level of self-focus from -3 to +3. +3 is totally externally focused. Most individuals with BDD are somewhere between -2 and -3. One of the things we use, attentional training, which is attempting to get them to be externally focused by listening to the sounds in their environment, looking at colors, different colors in their environment, one at a time, then combining all of these. You may do 7 sounds, 7 colors, combinations of sounds and colors. Practice this 15 minutes twice a day. Practice it first with the patient, then have them do it as a homework assignment. Next is task concentration, listening, then speaking. Have the patient face away from you and you tell a 2-minute neutral story. The next is the patient is facing you, again a neutral story. Then an appearance-related story when they're not facing you, and an appearance-related story when they're facing you. Task concentration that goes on to engaging the patient on a task and having them focus externally, like your attentional training, while they are walking in a mall, while they're putting makeup on, while they're talking to a salesperson or giving a talk. So they're engaging in a task and concentrating on different environmental stimuli. If they have skin picking, one of the things I want to emphasize here is basically the introduction of habit reversal, which I won't get into. And it's quite effective in hair pulling and in skin picking, stimulus control, becoming aware of the sensations prior to picking. And finally, relapse prevention. In a study, 2 or 3 studies done with Dean McKay and myself, we found those that engaged in relapse prevention after treatment did significantly better up to 2 years later. So we highly recommend you incorporate relapse prevention in your program. So that is the end of today's webinar, and I thank you for attending and going through this process with me. Thank you. Bye.
Thank you very much, Dr. Nazaroglu. If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer. ADAA members enjoy year-long access to continuing education programs, free access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, significant discounts to ADAA's annual 4-day conference, and much more. Please visit adaa.org to learn more. We would also like to invite you to check out more ADAA on-demand webinars by visiting www.adaa.org. On behalf of ADAA and our presenter, we thank you for joining us today.